Chapter 23, Behavior on Psych and Suicide Emergencies. So we're going to cover the behavioral and psychiatric emergencies that you may come across, and then the emergency care for those. Alright, patients may present with unexpected or dangerous behavior. This can result from stress, if they can't deal with the stress very well, don't have those outlets. Physical trauma or illnesses, drug, alcohol abuse, and different psychiatric conditions that are out there. So what is a behavioral emergency exactly? The behavior, manner in which a person acts or performs. The emergency is when the behavior within a given situation that is unacceptable or intolerant to patient, family, or the community. Behavioral patients may appear confused and have altered mental status. Sometimes it can be, especially with drug and alcohol. Patients with a history of psychiatric or behavioral issues, it can be very confused. They just have a altered look on reality at times. So some of the conditions: anxiety or panic disorders. There's a lot of anxiety in the world. People will typically take medications to control it. When that's not working, they typically will call for EMS. These can be minor anxiety attacks. They can be very severe. I've seen patients have anxiety attacks to where they physically cannot move. I'm sure that they could, but the anxiety has taken over so much that they're just zero help to you, and you have to move the patient. Depression, the varying stages of this, they can be mildly to severely depressed. Bipolar disorder, this is that roller coaster, or either extremely happy or extremely down, just extreme swings in their moods. Schizophrenia, you'll run into this much more than what you would ever think. Typically, it's treated with medications. A lot of times they stop taking them, and then you have no idea what you're going to be dealing with. So physical causes of it, of an altered medical and traumatic conditions that can alter a patient's behavior. You have low blood sugar. Remember, they become extremely confused. The brain's not getting the glucose that they need. Lack of oxygen. Again, the brain needs glucose, oxygen, and water, right? Don't have those, it's going to affect it. Stroke or inadequate blood to the brain, that's affecting the delivery of oxygen. Head trauma, this can be, it can affect different parts of the brain. There can be swelling, a lot of different things that head trauma can cause. Mind-altering substances, drugs, whether taken purposely or accidental. And environmental temperature extremes. Situational stress reactions. Normal reactions to stressful situations produce emotions. Fear, grief, anger. We've all experienced this. Caring for patients with situational stress reactions. Do not rush. Reassure the patient. Tell them that you're there to help. You yourself remain calm, which will help them to remain calm. Keep your emotions under control. Regardless of what the patient is doing, saying, you want to keep your emotions under control. This becomes much easier the more that you deal with these situations. But the first few times can be very stressful for you, which you may not act appropriately. Listen to the patient. Let them vent. Let them talk things through. Okay, don't rush them. Be honest with the patient for the most part. Sometimes you have to, depending on the situation, you may have to stretch the truth a bit in order to treat the patient appropriately. Stay alert for changes in behavior. These people are under a lot of stress. They're not dealing with it properly. They can become violent at any time. And depending on how they have dealt with the stress, if they have self-medicated, things can go south very quickly. Acute psychosis involves a severe break in patients' abilities to process info and interact with their environments. often associated with a cognitive disorder such as schizophrenia. Uh, Again, these patients, especially when off their medications, you have no idea how they're going to act. There is a schizophrenia guy in the Quad Cities. When he goes off his medication, he will literally sit on the counters and shit right there on the counter. His sense of reality is completely gone. Symptoms, hallucinations. Again, they have a false sense of reality. They're not fully there. Delusions, catatonia, and thought disorder. Ensure safety of patient and responders. Again, your safety, your crew's safety is the most important. If you feel that it's unsafe, definitely get police en route. So caring for these type of emergencies. Range of presentations on what you're going to see. They can be withdrawn, they can be not communicating, they could be extremely talkative, they can be agitated. A lot of different things that you're going to run into. No cause, same with these. They can have extremely bizarre behavior, or they can be very threatening. It all depends. Always be, on the lookout for changing conditions on scene. They can't wish to harm themselves or others. I've seen both of those. Uh, people that are suicidal and those that are homicidal. Key techniques. Identify yourself and your role. Make sure that they understand that you are there to help. Speak slowly and clearly. Gives them a better chance of understanding what's going on. Make eye contact if it's not making the patient uncomfortable. Sometimes with these schizophrenias, they don't want to look at you. They don't want you to look at them. Those I wouldn't make eye contact with, I'm going to keep an eye on the patient. I'm not going to look them directly in the eye. Listen to your patient. Regardless of how off the wall it may be what they're telling you, listen to the patient. You're going to somewhat gain some trust there. Don't be judgmental, okay? Use positive body language, as we've talked about before, and acknowledge the patient's feelings. Hey, I understand you're feeling this way. Okay, let's get you some help. Let's talk about this. Do not enter a patient's personal space. Stay at least 3 feet from the patient. This is to keep them calm and also to protect yourself. Get in within that 3 feet, they can quickly reach out and strike you, punch you, kick, whatever. Things can change in an instant on scene. Be alert for changes in the emotional stress of the patient, as well as your fellow responders. We're under a lot of stress with what we're dealing with, what we're responding to, and sometimes we don't respond appropriately either. So keep an eye on your crew as well. Use restraint to prevent harm if necessary. You want to avoid any physical contact as much as possible. There's going to be times you cannot, okay? But you want to use restraint to try to prevent that, but always put yourself. So you can see here, a little picture here. They got the patient surrounded. That can make the patient extremely violent at times. They do not like that. This is what I would say would be a last resort. You don't want to get to this position if possible. And if it does come to that, hey, usually you let PD deal with it. So the assessment. Perform a careful scene size up. You're looking for safety, right? Identify yourself and your role. Do your primary assessment, your ABCs, all that. Perform as much of a detailed exam as possible, as much as they will allow. There's going to be times where it's a psych patient, where all we do is put them in the ambulance and transport. We just kind of leave them be. That may be the most that you can do for the patient. Gather a thorough history of the patient's uncooperative family if possible, or look through their medications. May tell you a bit about their history. So some signs and symptoms for them. They'll have a panic, anxiety. It can be pretty extreme at times. Unusual appearance, disordered clothing, poor hygiene, especially when they're on drugs, etc. Uh, they just do not look normal. Yeah, you can just look at the person and be like, something is not right with them. Can be extremely agitated, unusual activity. They can be repeating things, have small tics. A lot of different ways they can present to you. Unusual speech patterns, can be slurred speech. They can talk with a certain cadence, may repeat certain things over and over again. Just look for abnormal speech patterns. Bizarre behavior or thought patterns, suicidal or self-destructive behavior, and of course, violence or aggressive behavior. Be alert for your personal safety and scene safety problems. Treat any life-threatening problems. Consider medical or traumatic causes for how the patient is acting. Spend time talking to the patient. There's no need to rush these calls. Encourage the patient to discuss their feelings. Never play along with hallucinations. Again, I'm going to kind of disagree with that one. That's what the book says. That's the national standard. There's going to be times you have to kind of play along to get the patient to be cooperative. And you need to use your best judgment on that. You don't want to feed the hallucinations or, take it a step beyond. Sometimes you acknowledge them to get the patient to agree to what they need to do. We had a patient one time, pretty sure he was high on some type of drugs. He was also a schizo, and we got called because he was by his school, acting erratically. He was hallucinating. He thought aliens were coming, and he was trying to protect himself, which is why he was just extremely odd behavior. We played into the hallucinations, okay, to get the patient away from the school, for the safety of the students as well as ourselves. So we told him, hey, we totally understand, like, we're here to help you. We want to protect you from the aliens. Okay, so we have the special vehicle over here. It's completely done up, the latest technology. Their radio waves cannot reach your mind inside this vehicle. Okay, and then we're going to take you somewhere where they can't find you and protect you. He agreed to it. He got into the ambulance, was cooperative at that point because he thought we were helping him to stay away from the aliens so they couldn't read his mind, etc. Sometimes you have to play along. Consider involving family or friends if they're willing to be involved. Suicide, 8th leading cause of death. 3rd leading cause in the age group ranging from 15 to 24. There's a rising number in the adult population, the elderly. There was a call just the other day where an elderly male was tired of living in chronic pain and he slit his wrists. Unfortunately, he cut in the wrong direction, which allowed treatment to be given so he didn't bleed out right away. A lot of the times, if you read the paper, a lot of the times when people die at home, it says, dead at home or whatever, you'd be amazed how many of those are suicides or drug overdoses. It's very prominent. Also in our field, EMS, firefighters, police, suicide is the #1 cause of death over anything else. Over car accidents, with firefighters, greater than heart attacks, suicide is the #1 cause of death. So always be aware of that. Patient assessment, potential or attempted suicide. Explore the following possibilities. Depression, high stress levels, recent emotional trauma, their age or they are at a higher risk, drug or alcohol abuse. It's not always necessary to determine the causes, okay? But if you can get the patient to talk to you, if you can gain that trust, you may be able to pass it along. Threats of suicide, if they've told anybody else that they're suicidal, if they have a plan, always ask specifically, hey, I understand you're feeling this way. Have you thought about any way to do it? If they can describe their plan, can also help with the care of the patient moving forward. Any previous attempts or threats of suicide, and sudden improvement from depression. Personal interaction with these patients is extremely important, if possible. Don't argue with them, don't threaten them, don't indicate any use of force. Okay? Ensure scene safety, identify and treat life-threatening problems as any call. Your secondary assessment, take your vitals, detailed exam only if safe, if they allow it. Reassess frequently. Notify receiving facility. Now, prior to even transporting a patient, if they are suicidal or they're making some type of threat, PD should be on scene. Ensure that the patient has been searched thoroughly. I did have a call where a patient was suicidal, was threatening other people, and I even asked PD, has he been searched? And they said, yeah. And we fought this patient pretty much the entire way to the hospital. Extremely combative. When we got to the hospital, we moved him over to the hospital bed. About a 6-inch knife fell out of his pocket. That was in his pocket the entire time in or out to the hospital that we were fighting this guy. PD said that they had searched him. What it ended up being is PD, the officer that rode with us, thought one of the other officers had searched him. Okay, so ensure that you talk to whatever police officer searched and make sure it was done prior to transporting a patient. So think about it. Patient is 23-year-old male. His girlfriend called 911 after a domestic dispute. He's uncooperative, refusing treatment, very typical. Girlfriend reports patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. Can you treat the patient if he did not call? This is a very gray area. Okay, you're going to stay on scene for quite a while. You're going to get PD involved. During a domestic dispute, people will say all sorts of different shit, to try to get the other person arrested. It happens all the time. But anytime that there is a possible threat, you need to take it very seriously. Should you believe the girlfriend? Yeah, it's going to be a case-by-case basis. Does the patient need treatment or transport? Depends. Again, is there any history of this before? What's the patient saying to you? Is he aggressive? Things you need to take into consideration. Can you transport the patient against his will? Just because he's conscious, alert, and oriented times 4. If he makes any comment regarding being suicidal or wanting to die, you can transport against his will. Okay? That's the state of Illinois. Definitely have medical control involved and PD if possible. So aggressive, hostile patients, consider clues, dispatch info. If they have a history of it, they will typically have information about that particular address or patient. A lot of times they'll have PD en route anyways. If it sounds like a possible violent call, PD will always be there to clear the scene prior to your arrival. Get information from family or bystanders, patient stance or position in the room. You can kind of tell when a person's standoffish, possible hostile or aggressive. Always have an escape route. Don't put the patient between yourself and the door, the exit. Sometimes you have to. Been in situations where I have, but I kind of enjoy those calls anyways. I enjoy it. So don't threaten the patient. Never make threats about violence. Okay, you don't want to provoke them, but always be ready to defend yourself. Stay alert for weapons of any type. These patients will a lot of times grab anything to use against you. I've had patients pull knives on me. Luckily, I've not had a gun pulled on me yet. They'll punch, kick, spit. We've had a brick thrown at us before. It happens. Always ensure safety. Try to keep the patient calm. Perform a thorough assessment if possible. If not, you just transport. Restrain the patient if necessary. Follow your protocols on that. A good one for this. You can have PD handcuff the patient and restrain them, and they can ride with you to the hospital. Scene size up. Request additional help if necessary. Seek advice from medical control if necessary. Watch for changes in behavior. Reassess and consider restraint. So reasonable force and restraint. Reasonable force is force necessary to keep patient from injuring self or others. Very gray area here. Reasonable is determined by the patient's size and strength, type of behavior, mental status, available methods of restraint. Some systems do not allow restraint without police or medical control orders. Never attempt restraint without proper legal authority and sufficient assistance. So excited delirium, extremely agitated or psychotic behavior during struggle, followed by cessation of struggling, respiratory arrest, and then death. This can happen. We've all seen stories of, I believe the last one that made national headlines was in New York. A guy was struggling against police, extremely agitated, violent. Then once they got him calmed down, he ended up dying in the back of the SWAT vehicle. Patient is often hyperthermic, extreme high temperature, and shouting incoherently. It's usually preceded by cocaine use. Often linked to improper restraint in a position where a patient cannot expand chest to breathe adequately. Positional asphyxia. So if you're using seatbelts, etc., on the patient to strap them down, you need to allow for chest expansion for breathing. Be alert for this sequence of events. Restraining a patient, have adequate help. Sometimes 2 guys is not enough. Definitely need more. Plan your actions out. Okay, you don't want to just fly by the seat of your pants on this one. Discuss how you're going to do it. Everybody has a role, and then stick to it. Stay beyond patient's reach until prepared, and then act quickly. So one EMT will typically talk to the patient, try to calm them down. It requires 4 people, 1 at each limb. Restrain all limbs with approved leather restraints in supine position, always. Really don't have leather restraints anymore. It's soft restraints, at least in Illinois. They're not the best. Definitely not the best. A lot of times they're Velcro. It's nice Velcro, but patients can't get out of it. Most of the time, I'm going to use a chemical restraint, or a PD is going to handcuff the patient. EMT is responsible for restraining patient's airway. Remember that. You are responsible for the airway. If you lose a patent airway, that's on you. And trust me, family will come after you. Ensure patient is adequately secured throughout the transport. Apply a surgical mask to spitting patients. You can also use a non-rebreather. Protect yourself. Reassess frequently and document thoroughly. Not all hospitals are prepared to treat behavioral emergencies. Know your area. Know where you're transporting to. Choose the correct facility based on capabilities and local protocol. Now, regardless, if you have an extremely violent patient, and you don't want to be in the back for a long transport. If there is a closer hospital, regardless if they have the means to treat it, you're going to go there. They can shoot the patient up with whatever medication to knock him out, and then somebody else can take transfer. So consent, refusals, and restraints cause significant medical legal risk. Laws typically allow providers to treat and transport patients against their will if a danger to themselves or others. Local protocol may require medical control contact and or police presence. Anytime you're going to transport a patient against their will, you need to contact medical control. Cover your ass. Sexual misconduct, behavioral patients, especially those requiring physical contact, such as restraint, sometimes accuse EMS providers. It doesn't even have to be, physical contact. They had a behavioral patient, a regular, okay. One of those like you don't take vitals, she's that uncooperative, but would always accuse people of rape. You have a 2-minute transport, but that's one. After the first few times, you always have another person in the back as a witness. It's ridiculous, but cover your ass. Have same-sex provider attend to the patient if necessary. Third-party witness in the back during transport. All right, quick review here. You're going to respond to many different behavioral emergencies. Whether they're legit or not, that's not for you to decide. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. And what I mean by legit or not legit, they have behavioral issues, but they call all the time because they would prefer to be in a hospital rather than at home. And they'll give you all sorts of different excuses to go there. A considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It is important to remember that patients in crisis are patients and people who need your compassion as well as your care. Always consider patients acting in an unusual or bizarre fashion to have an altered mental status. This will help you avoid overlooking a medical or traumatic cause for the patient's problem. Because of the treatment of these patients usually requires long-term management by a psychiatric professional, little medical intervention can be done in the acute situation. However, the way you interact with the patient during the emergency and assess your patient is crucial for continued well-being. You're building the trust in the system from the get-go. Safety is first priority, always. Any call, safety is your first priority. Psychiatric and behavioral emergencies are pretty common, and you should treat them as they would any other potentially life-threatening disorder. Assessment of the altered mental should rule out physical cause first. Psychiatric and behavioral emergencies can present differently, extremely differently, depending upon the disorder. Best practices EMTs employ in approaching, assessing, and treating such patients. Follow local protocols. Use appropriate procedures to restrain patients when necessary. Alright, what methods help calm the patient suffering a behavioral or psychiatric emergency? You staying calm, talking to the patient, allowing them to speak. What can you do when scene size up reveals it is too dangerous to approach the patient? You better have PD en route. What factors help assess the patient's risk for suicide? Now, if you've ever gone to the ER, they will specifically ask, do you have any thoughts of harming yourself or others? In pre-hospital, it's not something that we ask patients typically, unless we feel it's a suicidal call, okay? So they're not really going to come out all the time and tell you. You need to look for the clues, talk to people on scene, etc. So you respond to an intoxicated minor who is physically aggressive, threatens suicide, and whose parents permit you to treat but not transport the patient. How would you manage this patient? Yeah, typically with intoxicated people, they'll say a lot of shit that they don't really mean. However, you have to take any threat of suicide seriously. If they're physically aggressive, PD should be on scene. So you're going to treat the patient, comfort care at that point. But the parents don't want you to transport. You're going to have this at times. Definitely have medical control. Talk to them about the situation. If you feel that there is a danger to the patient, maybe neglect or abuse, definitely raise those issues with medical control. PD also has the ability to transport without permission from the patient or the parents. So you're going to have to look at the situation and see what's really going on. Okay.